Good morning, everybody. Bright and early. Fantastic to be here and see all of you. Welcome to our session here with a wonderful friend and great colleague, Dr. Neil Shore. We're both excited to see you. Just a couple of housekeeping items. As you already heard, this is going to be live streamed and recorded. Neil and me will be excited to run through a wonderful revolution in bladder cancer, right, Neil? Amazing things have happened in the last few years. I would like to thank Peerview Institute for providing this support and this session, as well as the sponsors, AstraZeneca, Bristol Myers Squibb, and Janssen, for the educational grants. If you have not already, please complete the pre-event survey. It's important to have this pre and post comparison, right? Look out for additional follow-up polling questions during the presentations. Please vote. Would like to hear and see what your thoughts are, learn from you. And please submit your questions, and Neil and me will try to answer them during the Q&A session. So feel free to make this interactive and use the iPad in order to pose the questions, because it's going to be broadcasted. So we're active in Twitter, as you know, so handle Peerview. And you can view the slides and practice aids now and download them after the event, so you can have access to the content and think about questions. We're going to start with Neil here. He's going to discuss the very important topic of addressing unmet needs in non-muscle invasive bladder cancer with innovative therapeutic solutions. And then we're going to do this together. Neil will start with reshaping the treatment algorithms for muscle invasive bladder cancer, focusing on the bladder sparing options, bladder preservation. And I will follow up with systemic therapy options, and I will finish off the session with a didactic of recent progress and current status of therapies in metastatic disease. So without further ado, my honor and pleasure and privilege to introduce Dr. Neil Shore. You all know Neil, needs no introduction. He's the medical director in the Carolina Urologic Research Center. He's a chief medical officer in the Urology and Surgical Oncology in Genesis Care, US, Myrtle Beach, South Carolina, and really a remarkable colleague individual. Neil, thank you for being here.
Well, Petros, thank you so much, and thanks everybody for being here and for tuning in virtually. I think, as you said, I mean, there really has been a revolution, and starting around 2016 with the first IO approvals, and we've seen the indications move more and more proximally. We're going to talk about that today, and bringing in the full multidisciplinary team of urology and medical oncology, radiation oncology to work together. I think it's just tremendous. Our topics today, as you've outlined, NMIBC, trimodal bladder sparing, and then neoadjuvant, adjuvant strategies. We really have the luxury of having an embarrassment of riches. And I think that's one of the things that I'm so excited about. I mean, to continue to have the intellectual vigor that we have in the clinic and in research is quite remarkable. NMIBC, everyone is familiar with the decades and decades of great opportunity with BCG. We know that NMIBC is a heterogeneous disease. We have high risk, low risk disease. We have strategies and decision making that we have to think about. We now oftentimes have supply chain shortages, whether it's with BCG, that varies depending upon where you are in the US, even where you are in the world. We have chemotherapeutics that we can also employ, both for patients who are at high risk versus low risk. We have pathology changes as to how we grade histopathology and how we think about it. And I think very exciting is all of the new NMIBC opportunities, in addition to having BCG as a relative standard of care, intravesical chemotherapies. And what we're going to talk about now is so many of the advancing a pipeline of pending approvals. So this is really great work. The IBCG, and its international input. And one of the things that we see here is these definitions that have evolved over time is what defines adequate BCG. Of course, we're familiar with patients who have less than adequate, and now that becomes its own interesting category. How do we design trials for the less than adequate BCG? How do we think about intravesical chemotherapy as a standard or a comparator arm for low risk, intermediate risk? Intermediate risk is a large unmet opportunity for trial design. And then, of course, what defines BCG unresponsive? Recently, there's been a really great workshop that happened at the bladder cancer think tank this year, where we heard the FDA said, once BCG unresponsive, always BCG unresponsive. So it's important for all of us to be aware of this landscape and how we can think about trial design and definitions. Here's a nice overview from both AUA and SUO, and SUO has clearly been at the forefront. The Clinical Trials Consortium, tremendous work that's been done. We'll talk a little bit more about that. But when it comes to our daily practice, academic or community, US or global, we have all these patients who come in regularly. There's no shortage of patients with bladder tumors. We do our TURBTs. We define whether or not they appear to be low or intermediate risk. Hopefully, they're getting post-TURBT gemcitabine based upon tremendous work that's demonstrated that value proposition, but we know that that doesn't always happen for various reasons. And then ultimately, are the patients considered based upon histopathology low, intermediate, or high risk? And where do we ultimately position induction BCG, maintenance BCG, and what about the patients who can't get BCG, and intravesical options and trial options? So there's a lot of opportunity for intravesical chemotherapy before I get onto this slide. And so it's interesting to me that we had mitomycin in the US. A recent market analysis we did shows that within the community, there's a tremendous amount of single-use gemcitabine. In academic centers, there's a much greater utilization of gemdosi. Mitomycin is really pushed down. And it's an interesting phenomenon. Is it related to complications of therapy? Is it an acquisition? There is always access considerations, economic, but I think it's very interesting to see where the community in the US is going in terms of intravesical chemotherapy. But transitioning just for a second now over to checkpoint inhibitors. I think this is really going to be a very exciting year in the world of BCG naive patients who are at high-risk disease. This phase 3 trial sponsored by AstraZeneca, the Potomac trial. I'm honored to be a co-PI on this with Maria DeSantis, a medical oncologist from Germany, and this will almost assuredly have a readout sometime in 2023. You can see the stratification, the inclusion, and this is the first major trial that will read out the use of a checkpoint inhibitor, durvalumab, with the various arms that you see here: induction-only BCG, induction maintenance, as well as just a standard of care, the 5+2, and then maintenance over the course of a 2-year period. At the very bottom of this slide, there are other really important trials that are very similar, almost identical trial designs. The Keynote 676, which is Merck-sponsored, and the CREST sasanlimab, which is interestingly a subcutaneous administration of an IO. And so these are all global phase 3 trials that will have readouts, and this will, if they're positive, will assuredly change the way we think about BCG naive high-risk patients. And we can talk more about that. Importantly, you see the phase 2 down here, that's the Sunrise-1, the ADAPT bladder. The Sunrise-1 is a fascinating use of a device that essentially has a osmotic pump. Some folks call this the pretzel because it looks like a pretzel. It's about the size of 2 quarters that goes in the bladder and delivers intravesical gemcitabine in the TAR-200. And that's in combination with the Janssen-sponsored study of citrullimab, their checkpoint inhibitor. The ADAPT bladder is looking at a multi-cohort with durvalumab as well. So this area of IO entering into the urologic arena, certainly in combination with our medical oncology colleagues, is very important. Now, that was the BCG naive. Now, what about the unresponsive? And this is not an exhaustive chart here, but we could spend an hour just talking about this. We can go around this wheel for our BCG unresponsive NMIBC patients. And one of the challenges is we know this is the particular group that's at very significant risk, not only for recurrence, but of a much higher likelihood for developing progression. And the progression biologic transition results in potentially a more aggressive therapy, including a radical cystectomy. So I've already mentioned the IO at the top. We have FGFR inhibitors, both oral as well as through that same pretzel device, the TAR-200 model that Janssen has. The area to the bottom or right of the screen, the Adstiladrin, thanks to the SUO Clinical Trials Consortium, Steve Bajoran, Colin Denny, almost everyone here, was really one of the landmark accomplishments of the SUO CTC to achieve this extremely important study. And I do believe that this is now in front of the FDA, and hopefully this will see Adstiladrin come into the market. Likewise, across from that is the IL interleukin 15, the superagonist for the ALT-803 from the QUILT trial. We'll talk a little bit more about this, but this is another example of BCG-unresponsive patients having additional opportunities. Moving down to the bottom here, we see there are many other alternative delivery options. There are a whole series of early phase studies looking at ablative strategies and tumor apoptotic effects that are really, really exciting. I'm sure many of those in the audience are involved in those. Towards the bottom, the oncolytic adenoviruses, whether it's the Cold Genesis product, multiple trials, Vaxion, multiple other companies. This is a very exciting area of utilizing combination viral vectors with immunoadjuvants that can enhance apoptotic effects with a mechanism of action that is not similar necessarily to BCG, and you can't have a meeting with urologists and immuno-oncologists and not recognize that we've been in the immuno-oncologic arena with BCG now for several decades. So this is just a quick review, the Keynote 5-7. This was a really important and major study that led to the first approval of an IO therapy, a checkpoint inhibitor, for BCG-unresponsive CIS. The CR rate, as you see here, 40% at 3 months, and this had durability and ultimately led to approval by the FDA and coverage by CMS, extended monitoring. One sees at the very bottom here, the tolerability, the immune-related adverse events, not atypical from what had been seen earlier with pembrolizumab. But this is certainly an area for urologists that are continuing to have to learn how to recognize, educate patients. But this opens up an opportunity for patients to consider therapy, BCG-unresponsive CIS, who would prefer to avoid cystectomy. I mentioned the QUILT trial, remarkable results. And if you look at the CR here at 3 months, 71% CR. And this is looking at the N803. This is really the mechanism of action, more complicated than just saying it has a positive impact on natural killer and T cells, augmenting the immunologic response, being studied in other cancer types besides bladder cancer. But ultimately, one sees the efficacy summary of cohort A, and the safety and tolerability was actually quite remarkable for a purely intravesical therapy in combination with BCG. I mentioned the phase 3 on Adstiladrin. Prior, we called it Instiladrin, but nadofaragene firadenovec. We published this in Lancet Oncology. We published our earlier phase 2 in JCO. And again, this is really a tremendous work that was accomplished by the SUO-CTC. And I think this is in front of the FDA, and then hopefully having a correction in some recent manufacturing issues will, I'm optimistic that we'll see this in the clinic in 2023. So I mentioned earlier there's other things on the horizon. This is as if this wasn't enough. FGFR inhibition, I think Petros is going to talk about it, and it led to the first approval of oral erdafitinib as third line in advanced metastatic urothelial carcinoma. But what we know is the avidity and the prevalence of FGFR receptors is even higher in the NMIBC arena. So this is a great area that's being studied both with oral and device deliveries. And again, that kind of really fits into the urology wheelhouse. I've mentioned earlier the early cutting-edge work that's being performed by Genesis. It's an adenovirus and an oncolytic vaccine. And then at the very bottom here, we see other applications, intravesical, for example, the use of the reversible temperature devices known as the Vestigel. They have approval in upper tract disease. But they're looking at it as well, and also additional formulations that combine that with toll-like receptor inhibitors. So with that, it's sort of an interesting, as I said, it's a whirlwind of so many opportunities for our fellows and residents and trialists, but also, most importantly, to advance the clinical armamentarium for patients. It's because at the end of the day, if you have high-risk NMIBC, you want to keep it, you want to prevent progression and avoid surgical intervention as much as we all enjoy operating as urologic surgical oncologists. So here's a case. A 65-year-old patient, it could be a male, could be a female, but here we have, yes, resection, high-grade disease, per guidelines gets a repeat resection. There's no residual tumor. And so what are the opportunities? If the patient were BCG naive, if one could argue if he were BCG unresponsive, and how do we think about intravesical versus parenteral and systemic approaches? Ultimately, how do we deliver this? How do we work best with our colleagues in medical oncology? How do we think about the implementation and the throughput? And of course, the heterogeneity of bladder cancer mirrors the heterogeneity as to how we practice healthcare in this country and every other country in the world. And how do we talk to our patients about their risk-benefit analyses for doing these treatments? Petros, maybe and then we can go forward, but your thoughts on a case like this?
Neil, you did a fantastic job outlining all these amazing data sets. I think, the best we have right now in BCG naive population, until the trials read out, you mentioned the Potomac, the CREST trials, is intravesical BCG for high-grade disease, T1. So I think it's a discussion, of course, with colleagues like you, experts like you with urology. The TGRBT repeat was done, which is very, very important because the risk of understaging is very high, can be up to 50%, especially if you lack muscularis propria, about 20% if you have muscularis propria. So I think it depends on the risk stratification. If there is no any very high risk factors to make you discuss the option of radical cystectomy, I think most patients will probably get intravesical BCG. The question is, how do you deal with a national BCG shortage, which is a manufacturing issue? Do you go with the classical induction, of course, and 6 weekly doses, repeat, of course, evaluation in the bladder, and then if there's no persistent T1, that will be an indication for radical cystectomy at exactly after induction, you can continue with maintenance. And then, based on the SWOG trial, ideally, if you have BCG available, you go with a 3 years maintenance schedule of BCG. The question is, how do you manage BCG shortage, of course?
Yeah, I would agree with all that. Just for time purposes, we have a polling question that you're going to get right now. If you could please answer that, that would be wonderful. So just take a moment to use your pads, and then we'll go to the second segment on trimodal bladder sparing.
Neil, may I ask very quickly, any issues with the shortage at your side, or you have adequate for now?
We've been really fortunate, and I just find it really rather fascinating. We have not had a shortage, but we were really good at prioritizing, not overutilizing in low-risk patients. And there's the occasional intermediate risk, but we've been actually very fortunate. We've always had good upfront education on patient expectations and strategies so that we had very few BCG intolerant patients,
sure,
short of those who had really poorly compliant bladders. So I think the way the allocation was done was based on volume. So we were always very high volume, and so we've been very lucky. And
sure.
But I empathize for many of our colleagues who don't have that.
Thank you.
So let's go to my second segment here, and this is an area that I'm actually very passionate about because RC, radical cystectomy, done well with an extended node dissection is a tremendous life-saving operation, no doubt about it. But I think the surveys always demonstrate that patients, if given their druthers, and if they have a really crippled bladder, would much rather maintain their bladders. And from an RVU standpoint, we see that a radical cystectomy and an extended node dissection, I think, is one of the highest RVU allocations you could conceivably have. It's a very significant, technically challenging procedure that thanks to the SUO and leadership, work is done, and the teaching has led to much greater expertise throughout the U.S. and throughout the world. But really, even the appropriate TURBT is something that can't be taken for granted. And so what ultimately happens in the trimodal bladder sparing, and great work done by Jason Estathiou and Bill Shipley up in Massachusetts and other parts in the world, UK and Utah and others, have really started to pioneer this notion around, can we do bladder sparing, trimodal chemoradiation, concurrent chemoradiation, and allow for bladder preservation? And you can see the algorithm here. If you have a complete response, you move forward, you have long-term surveillance. And these patients, and at least in my experience, are remarkably happy to have gone through this and maintain adequate, good quality bladder function. Of course, if there's an incomplete response, then these patients have to be followed very vigilantly for potential salvage cystectomy. So what about some of the trials that are out there right now? So it still, I think, is the minority of locations that are comfortable not moving right to radical cystectomy. So here's the Keynote 992. This is an ongoing accruing trial, and these are for patients who have T2 to T4, obviously no metastatic disease. They want bladder preservation. They're chemo eligible. They don't have Galsky criteria issues. And then you see the randomization of chemoradiation plus pembro versus chemoradiation and placebo infusion. And this is actively accruing, and I think that this is really this opportunity to combine multiple mechanisms of action in patients who have particularly anatomically acceptable locations of their malignancy. I do think it's really important that a very aggressive TURBT from optimal maximal debulking is completed. There are other examples of this. This is another really important study, 475 patients, similar inclusion criteria on concurrent chemoradiation. And there are various choices that our medical oncology colleagues can choose. There's typically 3 to 5 that are offered. Some are a little bit different depending upon where you are in the world, but ultimately this trial, like the 992 Keynote, is chemoradiation therapy plus adding a checkpoint inhibitor, atezolizumab. Now, interestingly, and unfortunately, we just heard this week that they dropped their first-line indication for atezolizumab. Kind of ironic and sad, as they were the first indication, and they had that sort of a conditional approval. But nonetheless, they're still, Genentech Roche is still investigating. I mentioned earlier the use of the pretzel technology. Interestingly, that started with the use of lidocaine for IC patients, and I was fortunate to be part of that, but this TAR-200 is remarkable. You see the pretzel in the cartoon at the bottom, and it literally is the size of about 2 quarters. It is sublimely easy to insert and remove. So, and it can be done in the clinic. There's no need for any kind of IV sedation or general anesthesia, and the patients tolerate this remarkably well. I find better than even having an indwelling double J stent. But what's really kind of remarkable is the ability to allow for this osmotic pump delivery over time. Now, gemcitabine is part of the Sunrise platform, and there are 4 trials. There's the Sunrise 1, 2, 3, and 4. This phase 3 trial, as you can see here, is for patients who are looking for bladder preservation for all the reasons that we've already articulated. And there's a randomization 1-to-1. Again, their proprietary checkpoint inhibitor citrilimab versus the installation of the TAR-200 with gemcitabine on a Q3 weekly basis. So you're really sort of combining intravesical direct urothelial mucosal application of a well-described drug, gemcitabine, clearly has efficacy, as well as a systemic therapy. And so there's the opportunity here in combinations to further allow for bladder sparing. Here's another example of this is AstraZeneca combining, this is a phase 2 study, but combining not only a PD blocker but a CTLA-4. And we've seen the incredible success of that in metastatic renal cell carcinoma and other cancer types. And so why not look at it here as well, again with the hope of allowing for bladder conservation. So this is a durva-tremi combination, and then going on leading into radiation therapy, and depending upon the extent of that, depending upon nodal involvement or nodal, just within the pelvis. And then, of course, all of these trials require very, very rigorous, vigilant follow-up with endoscopy and biomarkers, typically in the form of cytology. And here's another really interesting study, and this was Matt Galsky has been pioneering this. This comes from the Hoosier Cancer Research Network, the GU 16257. What I like about this is that they're really now trying to get into this notion around genomic profiling. And so there's a recent work has come out demonstrating that you may find upwards of 4% of patients having homologous recombinant repair alterations. We're all familiar with that landscape in prostate cancer and breast and ovarian and pancreatic. And I think this is a great opportunity in bladder cancer to try and see, as you can see here, really, isn't it interesting that these patients got a Gemcis plus nivolumab. They underwent their sequencing, which I've been doing for quite a long time, even though I know it's not in the guidelines right now for bladder cancer, but I like it because I want to understand not only FGFR avidity, I also want to understand tumor mutational burden. I still like to understand what the PDL status is as well. But interestingly, for the patients who had CRs, 30 out of the 31, went on to no cystectomy. So that kind of tells you a lot about what patients desire, and then going on with a maintenance nivolumab. The swimmer's plot to the right it's still, these patients are continuing to be followed, but I guess what I find particularly compelling about this trial is not only are we looking at bladder preservation, but we're also getting ourselves into that important mindset of genomic profiling in bladder cancer. If we had time, we're doing more and more of that in kidney cancer, keeping it in our GU realm for uro-oncologists. So here's a second case. We have a 64-year-old man. He's good performance status, and of course, so many of our patients who come to us with muscle-invasive bladder cancer and even non-muscle invasive, depending upon where you practice, they tend to be a little bit more on the elderly side. Not always, but oftentimes they do have performance status issues, smoking, alcohol use, possibly environmental toxicities. Maybe they were working in factories, petrochemical exposure, et cetera. But nonetheless, there is heterogeneity, and some patients just have the misfortune, and possibly this is biological and genetic. So he gets a TURBT, he's T2, he's based upon his evaluation, presumably a CT scan. We talk about other imaging modalities, but there's no signs of disease outside the bladder. He's got reasonable GFR and clearance, typical cardiovascular, and he doesn't have issues of neuropathy or hearing loss, which would preclude him from having platinum-based chemotherapy. So I guess what I haven't put in here to this is, what's the location of the tumor and how aggressive can we be? Are there predisposing exclusions for trimodal bladder sparing? Is tumor too close to the ureteral orifice, pre-existing hydroureter? Petros, you probably are getting more and more of these at Tumor Board, and how do you approach it?
Neil, again, fantastic presentation. I think this is a great case for our multidisciplinary bladder cancer clinic. We have this at the University of Washington every Tuesday morning, and we have patients like this and even more complicated. And the question here is, as you mentioned, are there any particular factors that may make us think more or less about bladder preservation? You already alluded to, the presence of the tumor, near the ureteral orifice, obstruction with hydronephrosis, extensive diffuse carcinoma in situ, a very, I would say, crippled, quote-unquote, bladder with, a very poor bladder capacity and a lot of bladder symptoms. Those may be factors to make us think more about surgery, radical cystectomy, and pelvic floor dissection. On the other side, if in the absence of those factors, I think a patient like this, especially with smaller tumors, solitary tumors, T2 or T3A, may be great candidates for bladder preservation. And I think we should discuss with the patient and give them an equal, balanced, thoughtful discussion about neoadjuvant chemotherapy, cisplatin-based combination, docetaxel or gemcis for cycles, followed by radical surgery, or bladder preservation. And I think that's a very fair point. And I think the message to the audience is, please do discuss this option of bladder preservation. And you alluded to already, Neil, very quickly, the 3 radiosensitizing chemotherapy options in those patients that we use is either cisplatin alone once a week for cisplatin-fit patients, or 5-FU-mitomycin C. There was a paper from Nick James in UK, 2012, the BC 2001 trial, and or gemcitabine alone is a third option, either once or twice a week.
So that's great. Got a few questions here. We got a little bit of time before we get to your segment, so we're doing good there. How to best coordinate between urology and oncology when managing a patient with progressive disease. So, it seems so basic, and I was talking to a friend of mine right before the program, but it wasn't always so basic, and there was really these I think, unnecessary demarcations, or town and gown, internecine warfare within specializations. And I think that, that should all be yesteryear conversation. What's in the best interest of patients, whether it's getting a systemic therapy that can have grade 3-4 toxicities, but he or she is amenable to it, having that full-throated shared decision-making conversation, but making sure that you have a really active, ongoing collaboration with, as a urologist, since we're at the SUO, with your medical oncologist or a uro-oncologist within your practice who is really dedicated to this, because it's not the easiest thing, and also your radiation oncology colleagues. And then the patients, fully armed, can make the best decision. Petros, has your experience evolved over time since, I know you just finished residency like 6 months ago, but...
Less than that. I wish. Thank you, Neil. I think you hit the nail on the head. I think it's the key is multidisciplinary discussion, and it's my favorite clinic, right? Every Tuesday morning when we have this, we have urologic oncology, medical oncology, radiation oncology, pathologists and radiologists in the same room. The trainee sees the patient 8 to 9 a.m., and then we have a tumor board 9 to 10. It's a resource-intense setting, but the patients love it, it's patient-centered. And yes, my thought process has evolved over time. I'm definitely more open to the bladder preservation, as you mentioned before. We do not have a phase 3 trial comparing radical surgery with bladder preservation, but I think with proper patient selection, the outcomes at least look similar and comparable.
Yeah, it's really interesting that you mentioned that. I think that's a great trial. We'd like to see it. That'll be a very hard trial to do.
For sure.
Because patients will say, well, wait a minute, I got randomized to the RC. I'm out of the study. I'm going to go and do this otherwise. That's been my experience. But thanks, Petros. So let me hand it over to you.
Neil, fantastic job. And just to add one more thing, for bladder preservation, as Neil alluded to, maximum TURBT is very important, complete resection of the tumor as possible. Of course, try to avoid perforation. But this is a key thing before concurrent chemoradiation, and now we have trials like the Salk Energy 1806, that will evaluate the role of immunotherapy, which is still experimental in bladder preservation setting for now. So just a reminder for everybody, please answer the polling questions, very important for us to learn from you, and please keep posting questions. After Neil did the amazing tour de force, I have a very high bar to meet here, but I'll try to do my best follow through. So we have a lot of discussion about reshaping the treatment algorithms for muscle-invasive disease. And I'm going to briefly review, what has changed in the last few decades, answering Neil's question, neoadjuvant chemotherapy. I think it was a really long effort, and SGO has done a great job, trying to, discuss the data, and the level 1 evidence strongly supports that neoadjuvant cisplatin-based chemotherapy is a standard of care for muscle-invasive bladder cancer, T2, T3, or T4A resectable disease, and we have two options. We have either the dose-dense MVAC with growth factor support. All drugs are given one after the other on day 1, given every 2 weeks. This is different than what you see in that slide. That slide is comparing the classical, older, conventional MVAC that was given on 28-day cycle, much more elaborate, more toxicity. This has been replaced now by the dose-dense MVAC with growth factor support. It's shorter durations, about 6 weeks, because you're given every 2 weeks for 4 doses. The other option is gemcitabine cisplatin, and we actually, it's interesting, we never had a neoadjuvant phase 3 trial with gemcis versus radical cystectomy alone. However, gemcis has, I would say, been used for a long time. And we have now a couple of trials comparing gemcis versus dose-dense MVAC. One is called SWOG 1314, the other is called the VESPER trial. A lot of discussion there, but I will just say either regimen is reasonable. My slight preference in fit patients who can get it, I try to use dose-dense MVAC with growth factor support for 4 cycles, but gemcis is a reasonable alternative, again, for neoadjuvant chemotherapy in fit patients, of course. Of course, the question is, not all the patients are fit for cisplatin. Dr. Galsky in Mount Sinai and colleagues, about 11 years ago, they published in JCO the famous Galsky criteria, and they asked oncologists in a consensus-based approach, how do you feel about giving cisplatin? What are the criteria in your clinic that make you more or less likely to give cisplatin? And this came up to be performance status, kidney function, absence of significant neuropathy, absence of significant hearing loss, and absence of symptomatic heart failure, ECOG PS 0 to 1, and creatinine clearance 60 or higher. Now, of course, can be discussion about the hearing function with the patient, a little bit subjective. Some patients may tolerate a little bit high frequency loss. Creatinine clearance cutoff threshold is also variable among medical oncologists. The point is that some patients can get cisplatin-eligible patients, and on the right side, you see a number of clinical trials try to improve upon the backbone of chemotherapy, right? So you have, as I mentioned, dose-dense MVAC or gemcis, and those trials, Energize, Niagara, Keynote 866, and Keynote B15, are trying to build upon that. And we have the gemcis plus minus nivo, plus minus durvalumab, or plus minus pembrolizumab, and we have a promising combination, pembrolizumab plus enfortumab. All those are in clinical trial phase 3 stage. As of today, the role of checkpoint inhibitor remains experimental. So outside the context of a clinical trial, I'm not using checkpoint inhibitor in the neoadjuvant setting. We'll talk about adjuvant in a second. About half of our patients are not fit for cisplatin based on the Galsky criteria, as I mentioned before, or a variation of those. And for those patients, the options are either go straight to surgery, a radical cystectomy, lymph node dissection, or, as Neil mentioned a minute ago, bladder preservation, which, by the way, can be an option also for cisplatin-eligible patients. Think about that all the time in properly fit patients. And the other option is clinical trial, which is my favorite 2 words, clinical trials. In the morning, wake up in the morning. So we have a number of trials in this setting, cisplatin-ineligible patients. We have the Keynote 905, Pembro plus EV, Dr. Sompav, this leading trial with ADSWOG 2011, Gemcarbo plus avelumab, and we have the Volga trial, very interesting, with durvalumab and tremelimumab, anti-PD-L1, anti-CTLA-4, plus enfortumab vedotin being evaluated for cisplatin-eligible patients. As I mentioned, these phase 3 trials need to be accrued. Hopefully, we'll have results in the future. And all those phase 3 trials are supported by very promising phase 2 trial data. The last one by Dr. Gupta and many other trials you see in that slide that look at combination of gemcis plus a checkpoint inhibitor. Bottom line, very promising data supporting phase 3 trials. However, as of today, if you ask me, I'm not using a checkpoint inhibitor in the pure neoadjuvant setting. I'm waiting for the phase 3 trials to read out. But the data I'm seeing here make me very enthusiastic for the future. And a shout out for Dr. Gupta's BLAST1 genomic correlate analysis. Interesting biomarker work here. It's actually today at 1 p.m. You want to see her abstract. Now moving to the adjuvant setting, let's say a patient gets a radical cystectomy, pelvic lymph node dissection, which is always very important. What are the data with adjuvant immune checkpoint inhibitor? We talked about the neoadjuvant checkpoint inhibitors, experimental, very promising phase 3 trials. However, in the adjuvant setting, we have a checkpoint inhibitor approved already, and that's nivolumab. There have been 3 trials designed. 2 of them have showed results. I'll go through the trials with you. IMvigor010, atezo versus observation, CheckMate-274, nivo versus placebo, different control arm there, and Ambassador pembro versus observation. And here is the IMvigor010. This was overall a negative trial, meaning the adjuvant atezolizumab did not prolong disease-free survival or overall survival in the adjuvant setting. And there was an interesting work. This was published already by our team. Dr. Hussein presented the data at ASCO 2020. So negative trial with adjuvant atezo. However, you can learn a lot, right? When you lose a game in soccer, the World Cup now, you can learn a lot, right? And you want to learn from a negative trial. So in that case, we did a lot of work with Tom Powles and colleagues. We published this in Nature. And what you see in the slide, on the left part of the slide, you see a putative prognostic role of circulating tumor DNA. So that's something that right now I think is very promising, and it's an emerging biomarker. Personally, I'm not using it yet in clinical practice in the neoadjuvant or adjuvant setting, but I think it's coming. If you ask me what's the most promising biomarker in bladder cancer, I would say ctDNA. So we're getting there in the future, and what this slide shows, ctDNA detectability, positive status, portends a shorter survival. So if you are ctDNA positive after cystectomy, higher chance of recurrence, shorter survival compared to ctDNA negative status. On the right slide is the question, the premise or promise of predictive role. Does the presence of positive ctDNA predict benefit with adjuvant atezolizumab? And that's the hypothesis in that exploratory analysis from that trial. We saw, and we published this in Nature with Tom and others, that if you have a detectable ctDNA, you may benefit from atezo. If you're ctDNA negative, you do not. This was an exploratory analysis. That's why I'm not using it yet in clinical practice, but actually has led to the conduction of what you see in the left lower corner, the blue box, IMvigor011, atezo versus placebo, only in ctDNA positive patients. So you select the patients based on the DNA, and these patients get randomized to atezo or placebo. And a similar trial in Denmark called Tombola trial, they take patients ctDNA positive, get atezo, ctDNA negative, they don't. So with these trials are going to evaluate whether it's clinically useful or not to use ctDNA. So something promising. In my opinion, we still need more data, and those trials will show those data. Having said that, we have an FDA approval in the US as of August 2021. That's adjuvant nivolumab, anti-PD-1. What is the data behind that? The CheckMate-274 trial. These are patients who may or not have received neoadjuvant cisplatin-based chemotherapy. They come to the clinic, and if they had prior neoadjuvant chemo, they have a PT2 or higher stage. If they never had neoadjuvant chemo, it's PT3 or higher stage, or node-positive disease. And in that slide, you see on the left the disease-free survival in the overall population, intent to treat population, ITT, that showed overall it shows disease-free survival benefit, hazard ratio 0.7. On the right is a PD-1 positive 1% or higher, even higher difference, hazard ratio 0.53. We have not yet seen overall survival data. We're still waiting to see that, but based on the data you see in that slide, the FDA, and of course many patient advocacy groups agree with that, they approved adjuvant nivolumab in the adjuvant setting for patients with high-risk urothelial cancer. That includes upper tract disease, although the subset there was smaller, let's say, but the approval exists for both bladder and upper tract. And as I mentioned, this was based on DFS data in the overall population. So what you see on the left, the ITT, is what FDA approved. What you see on the right, the PD-1 high, is only what happens in Europe. So EMA approved it only for PD-1 high patients. In US, is approved for all patients, regardless of PD-1 expression. Toxicity data, important to discuss with the patient. I'll focus your attention on the second column, nivolumab. You see that it's about 18% of grade 3 or higher treatment-related adverse events. Think about skin itching, skin rash, fatigue, thyroid changes, diarrhea, rash, and think about overall immune-related adverse events. It's very important to have experienced nurses, advanced practice providers, and colleagues, either urologists or medical oncologists, Either way, but someone has been trained in order to be able to follow this patient, educate them, and diagnose and manage early immune-related adverse events across the board with immunotherapy, not only in that particular trial. The control arm was placebo, as I mentioned. Very quick word, there was some data published that in this disease-free survival benefit with adjuvant nivo was associated with no detriment in quality of life. So those patients had prolonged disease-free survival. The median difference was about 11 months or so, and there was no deterioration in quality of life because the treatment was overall well tolerated for most patients. So let's go to a case here. So we have a 69-year-old lady that had evaluation for hematuria, showed the sessile mass in the bladder, and this was resected and showed muscle-invasive disease, good kidney function, denies neuropathy, hearing loss, heart failure. Again, the GALSI criteria come to play here. Excellent performance status, underwent neoadjuvant chemotherapy with GEM-CIS, we talked about that before, followed by radical surgery, and had a neobladder. It was fit for neobladder based on kidney function in other regions. The pathology came back despite the proper use of neoadjuvant GEM-CIS here. The patient had a T3A, so microscopically nil disease. The tumor went out of the bladder. Historically, the standard of care has been observation. We have no good data about giving more chemo. We gave it already, right? This was kind of platinum refractory, in my opinion, but you had to give neoadjuvant chemo. You have no good biomarker to know a priori. So right now, based on the CheckMate 274, I just showed you the slides, adjuvant nivolumab is an option. And any comments, Neil? Do you discuss it with the patients?
Yeah, absolutely. So that was really great, Petros. Yeah, you're absolutely right. I mean, so here's this relatively healthy woman. She's gotten through her surgery well. She's had neoadjuvant standard of care platinum-based therapy, but yet her pathology is aggressive and concerning. So then she comes back to the clinic and says, okay, am I cured? Am I done? Is this it? And I think here's this really important discussion to say, well, we can offer you this systemic therapy, which 80+% of patients tolerate remarkably well. There are the grade 3, 4 IRAEs, but I think as long as there is really important discussion regarding these itises that can happen in virtually any part of the body, we typically see the most common with maybe, colitis, dermatitis, pneumonitis, some thyroiditis, but it can happen in other parts of the body. But that's where I think having that conversation to say, I want to optimize my curability, because once they show back up with metastatic disease on imaging, and we don't have the luxury of having a bladder version of PSMA PET, so then what else can you offer this patient who says, I really have a good actuarial survival and I want to ensure that I don't develop recurrent disease? So I actually think that this is remarkably important data and an important discussion that our surgical oncology colleagues have to make sure they're getting with our medical oncology colleagues.
Fantastic, and this is the importance of multi-discussion here. So I'll go a little bit quick here, just to remind everybody, please answer the polling questions. I will move on in the next 10 minutes, leave a couple of minutes for questions at the end, metastatic disease. Very quickly, we have data with platinum-based chemotherapy, ideally cisplatin, that's my preferred option in metastatic urothelial cancer first line. GEM-CIS is the most commonly used regimen in patients who have not received platinum for at least a year. There was a study about 20 years ago that showed that GEM-CIS seems comparable to the classic older MVAC, but has less toxicity. Is one which we use most commonly in metastatic disease setting. Dose-dense MVAC can be used in selected patients. This is a slide that shows a plethora of phase 3 trials trying to evaluate checkpoint inhibitors and other agents in the frontline setting. From all those trials, only one has changed practice, the Javelin Bladder 100, with switch maintenance avelumab after response to stable disease to platinum-based chemotherapy. So that's an important slide because it gives you a plethora of trials. And the NAL trial is ongoing. That's a chemotherapy alone versus chemotherapy plus durvalumab, anti-PD-L1, versus chemo plus durva plus tremi, anti-CTLA-4 and PD-L1 combination. This trial is ongoing. We have not seen data yet. We stay tuned. That's a Javelin Bladder 100 trial, as I mentioned before. Patients who achieve response or stable disease, no progression with platinum-based chemotherapy, they have significant overall survival, progression-free survival benefit with avelumab as switch maintenance therapy, and this can start between 4 and 10 weeks after the end of chemotherapy. I tend to start sooner than later in those patients, and I have a discussion a priori with them. And this is the longer follow-up here. You see significant OS and PFS benefit with switch maintenance avelumab in the frontline setting. And this was regardless of which chemo was used, gem-cis, gem-carbo, number of cycles of chemo, response or stable disease to chemo, and duration of the treatment-free interval. As I mentioned, I try to use cisplatin in fit patients if I can. There is a plethora of maintenance trials, main CAV, cabo avelumab versus avelumab, preserve 3, looking at the CDK4/6 inhibitor, the Javelin Bentley, trying to build upon Javelin Bladder 100, looking at combinations, avelumab plus something else, and the cohort 4 of Trophy trial, look at avelumab plus sacituzumab. All those are ongoing right now, but avelumab maintenance is the standard of care. There is a study that we're doing together with Joshua Meeks called Prevail, looking at biomarkers in tumor tissue and the blood. And I want to say a couple of words about the FGFR inhibition. Neil did a great job before discussing that in the previous section, and I want to point out that FGFR3 mutations or fusions are common drivers in this disease, especially in the low-grade non-muscle invasive disease, and also in upper tract more than in lower tract. And erdafitinib has accelerated approval by the FDA in platinum refractory metastatic urothelial cancer if the tumor has an FGFR3 or FGFR2 activating mutation or fusion. Not amplification, but mutation or fusion. And this was a single-arm phase 2 study. You see that on the left part of the slide. It was a single arm showing a response rate about 40% with erdafitinib in those tumors, platinum refractory, most of them that had no prior FGFR inhibition, but they had FGFR2 or 3 mutation or fusion. And we have a phase 3 trial ongoing. It's called Thor, and it's comparing erdafitinib with pembrolizumab or erdafitinib with salvage chemotherapy is ongoing. That's an option for our patients. That's why what Neil said is important, do genomic sequencing. I do it always at the time of metastatic disease in all my patients, if not earlier, to make sure we know the biology of disease and see about that option of erdafitinib in selected patients. Toxicity management is very important. Hyperphosphatemia, high phosphate level, very important to discuss with the patient. You may potentially titrate the dose based on the phosphorus level. This brings in the nutritionist, talk about diet, low phosphate diet, as well, if needed, in higher level of phosphorus and on calcium-containing binder with meals if the phosphorus is too high. And these patients have to see an ophthalmologist or optometrist at baseline and then during treatment to make sure there's no visual or changes or eye toxicity. Central serous retinopathies, fluid collection in the retina can happen in about a fifth of those patients. Usually it's reversible, but close attention with the ophthalmologist, and of course management of the side effects. We discussed already importance of genomic testing. I covered this. It's very, very important to do genomic sequencing, somatic tumor testing. Germline testing is very important too. It's a separate discussion, can help the family, cascade testing, cancer prevention. This is about somatic testing, and it's very, very important. Both urology and medical oncology discuss this again, especially in the context of advanced metastatic disease. A couple of words about antibody-drug conjugates, and there are two of them I want you to know that because they have FDA approval. Enfortumab vedotin, antibody-drug conjugate against Nectin-4, linked to a toxin, a chemotherapy drug called MMAE, inhibits the microtubules. On the right side is sacituzumab govitecan, anti-TROP2 antibody-drug conjugate. It's linked to SN38, which is a metabolite of irinotecan, a topoisomerase 1 inhibitor. So chemotherapy drugs linked to an antibody to try to go to a more targeted fashion against the urothelial cancer cells, because the targets, Nectin-4, TROP2, are expressed significantly in urothelial cancer cells. So it's kind of a magic bullet, so to speaking, more targeted chemotherapy. That's how I call them. Very promising data. The combination of enfortumab vedotin antibody-drug conjugate against Nectin-4 plus pembro is very promising. It's not approved yet, but we're watching to see what the FDA will do. We have some very interesting data from a phase 1b trial and phase 2 trial recently. Dr. Rosenberg showed the data at ESMO about 3 months ago. Response rate with a combination 65%. And as you see on the right corner, almost all patients had reduction in the tumor size with a pembrolizumab anti-PD-1 plus and enfortumab vedotin combination. We have about 76 patients. There were about 3 toxicity-related deaths, so it requires attention. About 2/3 of the patients had treatment-related adverse events. Very, very a promising combination. Keep an eye on that. Not approved today, but I think we're going to see what happens in the future. And there is a phase 3 trial comparing this combination with chemotherapy in the frontline setting. So gem-cis or gem-carbo versus pembro-EV, keep an eye on that. EV alone has a regular approval in the third-line setting after chemotherapy after checkpoint inhibition. EV has shown to prolong overall survival compared to taxane or vinflunine, and is one of the standard of cares right now in the third-line setting. And enfortumab has also an approval by the FDA in the second-line setting in cisplatin-ineligible patients. For example, you get carbogem, you have progression, cannot get avelumab maintenance, you can go to enfortumab as an option, or if you had first-line checkpoint inhibitor. Trophy U01, this is a trial for sacituzumab govitecan. Top line is a multi-cohort trial. Cohort 1 was published in JCO last year by myself, Dr. Tagawa, and others, and actually showed that sacituzumab govitecan, as a single agent, has an activity response rate 27% in a heavily pretreated patient population with multiple lines of prior therapy, metastatic disease, and so the median duration of response about 7 months. The toxicity profile is a bit different than enfortumab. It's more neutropenia and diarrhea. This drug has accelerated approval after chemotherapy and after checkpoint inhibition. So another momentarium option for our patients. And the phase 3 trial, TROPIC-04, is underway, sacituzumab govitecan versus taxane or vinflunine. Stay tuned for the results probably in the next year or two. And then moving forward here, I had the chance to present this data at ASCO GU 2022. This is a combination of pembro plus sacituzumab. Very promising data, not approved, not practice changing, just tells you that we try to combine antibody drug conjugates plus immunotherapy, and this data look very promising in my opinion. Toxicity is very important to manage, as I mentioned, with enfortumab, peripheral neuropathy, high glucose, keep around glucose on those patients. About 40% of the patients had skin rash on enfortumab, fatigue, low appetite, taste changes can be other side effects. Very important to keep an eye. With sacituzumab, a little bit different. Growth factor can reduce the chance of neutropenia and febrile neutropenia. Sometimes if needed, going to dose reductions, and diarrhea can be something to very carefully watch on, alopecia, fatigue, and other side effects. Anti-HER2 antibody drug conjugates are very important, coming in the future. So not approved yet, but one promising thing I want to point out, anti-HER2 antibody drug conjugates, very important as a promising tool in clinical trials in the future for metastatic urothelial cancer, either as single agents or combined with immunotherapy. So very quickly, Neil, 69-year-old gentleman, progression, fatigue, and back pain after 4 cycles of chemotherapy, could not get avelumab because has progression on carbogem, liver mets, bone mets, ECOG PS1, FGFR3 activating mutation, makes you think about erdafitinib. It's FDA approved for that setting, has no autoimmune disease, no other issues, but high hemoglobin A1c, 9.2, which makes me a little bit worried about enfortumab. So a neuropathy grade 1, obese patient. The question here is, if you have a patient like this progression on carbogem, what do? Do you use pembro is an option, enfortumab is an option, or erdafitinib? Hard to tell.
Yeah, this is a tough case, and again, it just really we got several questions on the iPads about the importance of the multidisciplinary team. This is a tough one. I mean, this patient has a lot of varying comorbidities, and then really having a full understanding of these unique adverse events of interest of these different classes of medication. I think the thing that was so remarkable about your Herculean review of all of this, Petros, was that one of the mantras that I have, whether it's in prostate or bladder or kidney cancer, but now even more so in bladder than it used to be, is how do we, when the patient gets his or her first shot, because typically your first shot is often the best shot, is to combine as many mechanisms, different mechanisms of action as possible, which is the beauty of all these trials that are ongoing. And I agree with you, clinical trials is a standard of care option. It's not experimentation. So that the biology of the disease can be thwarted, because bladder cancer, advanced bladder cancer, in comparison to prostate, is a much more virulent disease. So this is the kind of patient that says, well, okay, I've got bad disease, I've got liver lesions, I've got these comorbidities. How can you get me through this without just being nihilistic, which is really where we were 5 years ago?
It's a great point, Neil, and I will quickly say we just published a paper about a month ago looking at liver and mold mets. They're negative prognostic factors. These patients don't do well, especially if you progress on platinum, especially with IO alone. They have poor prognosis. I would say that if you want to go for a response, erdafitinib is an option here, or enfortumab. and I may preserve pembrolizumab for later on, or sacituzumab later on as well. Very quickly, we have maybe a couple of minutes before we close. Neil, I will take the first couple of questions, then I will ask you some of the rest. So, erdafitinib use, how we make sure we receive proper testing. Very, very important point. I do next-generation sequencing, tumor testing. Sometimes I do also circulating tumor DNA to look for mutations or fusions. I actually do both, tumor tissue testing and ctDNA generation sequencing is very important. Prevail study, stay tuned. We're going to present more data. We showed some data at ESMO on PD-L1 expression. We're going to show you more data from the Prevail biomarker study in the future. How soon to schedule cystectomy, Neil, after neoadjuvant chemotherapy or immunotherapy trials?
Yeah, I think that's a great question, and I think that typically, assuming that the patient had tolerated therapy well, and you're not having a problem getting it on your hospital OR schedule, I'm usually hoping to do it within a 3 to 4 week window.
Great, thanks, Neil. And we do the same thing at UW. We say between 3 to 5 weeks, depending on the patient's recovery and schedule. In your case that you presented, GFR was 61, I think. It was 55. Would you have the same conversation with the patient?
Yeah, so that's a good question. I mean, I think, it just depends upon what ultimately the chemotherapy regimen that you're going to pick, and that's where I would rely on my medical oncology colleagues to try to maybe avoid anything that was concerning for nephrotoxicity.
It's a great question. The different thresholds exist. Some of us may feel comfortable with GFR 50 or higher, with good education, hydration with the patient. Sometimes we may do cisplatin split dosing. One more question, and then I will keep this slide here just for you to take pictures. This is my own biased way how I treat metastatic urothelial cancer. Feel free to comment or question. I think we covered the question about bladder preservation and how you prepare the patient. Discussions should happen up front, ideally in the multidisciplinary tumor board, to discuss in a balanced way bladder preservation and radical surgery. We talk about that neoadjuvant immunotherapy is experimental for now, but we have very, very promising trials. And someone is asking about the Nile trial. It's very interesting. We have no data yet, but I'm waiting to see what the Nile trial will show. In that particular slide here, you're seeing I started with platinum-based chemotherapy for metastatic disease, followed by maintenance avelumab with response-stable disease. Second line, we discuss the options, pembro or erdafitinib in selected patients based on the biomarker, and fourth one, cisplatin-eligible patients, and so on and so forth. It's very important to have the multidisciplinary collaboration, Neil, right? The multidisciplinary setting, have a plan ahead, that simply transition patients from urology, medong, radong if needed, strong, solid relationships, advanced practice providers, communication with the patients, transparency, and of course, robust community outreach programs are very, very important. And maybe we can finish with this question, Neil. What are the key points that urologists should know when discussing the new standard of care based on the data we just saw?
So it's a great question. I love the first bullet underneath establish dependable relationships. There's nothing wrong with reaching out to your medical specialty colleagues. It's not a sign of weakness. And I remember talking to our colleague Noah Hahn, years ago, and I was doing a program with him, and he said, "Yeah, all this is sort of building up my internal medicine, DNA and bona fides. There's nothing wrong with having your a dermatologist or your gastroenterologist or your pulmonologist on speed dial. It's okay. It's not that you're not capitulating. So I think this effort and having folks to help you get through this, if indeed you're having any kind of a question, is a way to offer it. We know that we have to offer these therapies in the community. Our academic centers are the model, but academic centers can only treat about 15 to 20% of the advanced patients in the United States, and that's probably true all the way around the world. So we have to really embellish that. So I think that's really one of the key things. I did also want to just comment on the ctDNA, and I do think that's a very important biomarker. There's a lot of different companies that are doing that. I encourage colleagues to really learn more about that. They have approval in colorectal cancer, and I think the data that's going to be coming forward in bladder cancer is extremely compelling.
Totally agree. Very, very promising biomarker, and I think it's really, really great to see the emergence of biomarkers in this very, very difficult to treat disease, Neil. If we have any more questions, we'll be happy to take them. I think we covered everything here. Maybe one last one I see. Since checkpoint inhibitors are being used in both non-muscle invasive disease, what tips you would give urologists? I think you answered that, Neil, about managing toxicity. You just answered this in a great way, training, education, multidisciplinary team, and have someone who's dedicated and focused on that.
Yep.
because it's not a hobby, it's a full-time job kind of thing. Fantastic. I think we covered everything here. Please feel free to come find Neil and me. We'll stick around here after the end of this talk. I want to thank everybody for being with us today. And it's really exciting to see what is happening in the field. Please complete and submit your post-test evaluation for credit. I want to make sure we did a good job here, so give us your feedback. Download the slides and practice aids. Watch the replay of this event the next 24 hours, and online activity. Neil and me will be available. We're going to be active in Twitter. Thank you so much for joining us. Thanks to peer review. Thanks to the sponsor. Have a great day as you all.